Yes, it is time to move on, and we have reached on the second session of the day, which is about to commence. It is my pleasure to welcome our esteemed seasoned faculty for the second session, Dr. Anil Mirchandani. Dr. Anil has done his MBBS from Grant's Medical College and Sir J.J. Hospital, Mumbai. He completed his MS OBGY from Grant Medical College and Sir J.J. Hospital, Mumbai. With an additional qualification he holds is a fellowship in minimal access surgery. And just to add to that, he has further experience as ex-consultant and assistant professor, SAIT GS Medical College and KEM Hospital, Mumbai. He has got a vast teaching experience of 16 years. He is a university-approved UG teacher, teaching postgraduate students since 12 years. Consultant gynecologist in many private hospitals in and around Mumbai. We welcome you, Dr. Anil Mirchandani. Over to you.
Mirchi, 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 Tikhi Mirchi. You are with Mirchi. Hi everyone. Hello, this is Dr. Anil Mirchandani. That's me. Yes, Mirchi. Testosterone in OBGY. Hi, how are you? Everyone. My dear students, yes, we are ready for pushing it out, man. We are going to deliver this baby. Okay, baby? Yo, baby. My dear students, yes, we are here for our session called Visuals in OBGY. And we have many visuals, some graphics. And yes, we are going to cover them all. My dear students, as you all know, I am Dr. Anil Mirchandani. And I'll be taking your visuals in OBGY in these 2 hours. And I know you are absolutely excited for this session. And we are going to rock. That's my promise, Mirchi's promise. My dear friends, are you ready? Are you ready to push? Come in lithotomy position and push, man, push. Even man can push. Yeah? Something will come out. Something will deliver out for sure. And we are here for your revision in OBGY. And good news is that you have attended ma'am's lecture. Most of the things are already covered. But let's have fun time now. We will enjoy these 2 hours. Yes, after long hours of OBGY, let's have some fun time. Let's enjoy our fun time and chill out, man. We will learn as well for sure. But our main aim is to have every concept clear about the visuals in OBGY. Yep. Let's begin our journey. Let's start with the topics, the photographs, and we will be covering the topics in nutshell for sure. Yeah. So let's begin our journey. The question, the photograph which is lined up now is over here. This is the first photograph. Yes, I will have to sit because you will not be able to see the genitalia because of Mirchi over here. Mirchi, no. Okay, look at the genitalia. You are seeing a cystic swelling in the genitalia. It is in the vulva and it is at 5 o'clock position, as you can see. My dear students, this cystic swelling which is posterolateral to vagina is called as Bartholin cyst. Yeah, this is Bartholin cyst, my dear students. And if the cyst is anterolaterally placed, then we have differentials like Skene cysts or Gartner's cysts. 1 o'clock, 11 o'clock, Skene's and Gartner's. 5 o'clock, 7 o'clock, Bartholin cyst. Remember this. Okay, so these are Bartholin cysts. The treatment of this patient would be something called as marsupialization. Treatment is marsupialization, which means you have to open the cyst and evert the walls. See, Bartholin cysts have function called lubrication. Yep, and if you are treating Bartholin cyst, see, Bartholin's gland have function called lubrication. And if you are treating by excision, that lubrication element will go away. That we don't want, right? We don't want to have a loss of lubrication. Lubrication is very important in life. So, yes, my dear friends, the treatment is not to excise these cysts. The treatment is to open the cysts and invert the walls. This is called as marsupialization. Okay. The criteria used for a diagnosis of Bartholin gland cancer. So now there is one name called as Honan criteria. H-O-N-A-N, Honan's criteria. Honan's criteria is used for a diagnosis of Bartholin gland cancer. Yep. And it is basically having some components like location should be superficial perineal pouch. It should be below labia majora. The superficial skin must be intact. And histopath must show Bartholin tissue. So these are the 4 points of Honan's criteria. My dear friends, this is the first slide, by the way. Those who are thinking that you have missed something, no, this is the first slide. I have just started the session with this photograph of Bartholin cyst. Yeah, posterolateral vaginal cyst, Bartholin cyst. And the treatment is marsupialization for Bartholin cyst. If there is Bartholin's abscess, we will have to do something called as incision and drainage. And there is a specially designed catheter called as word catheter. Word catheter is used for incision and drainage of Bartholin's abscess. Yeah, we do marsupialization for maintenance of lubrication function. Yes, if there is an elderly patient with Bartholin cyst, we better do excision and then histopath. Okay, there we would apply this Honan criteria for Bartholin gland cancer. Okay. Am I clear? Right. So you can look into your books, DVT books. You can see over there, the photograph would be there. This is same photograph which I am displaying over here. Okay. Right. So this is Bartholin cyst treatment is marsupialization. Next question, next photograph. Next photograph is about early pregnancy. Early pregnancy will show this thing in uterus. This is called as, yes, what is this called? This is called as double bleb sign. Double bleb sign. Bartholin, previous question, B tissue is Bartholin tissue. Yeah. B tissue, histopath should show Bartholin tissue. Okay. Am I clear? Right. This picture which I am showing right now is about double bleb sign. This is seen in early pregnancy. This is nothing but a sac called amniotic sac. This black arrow is amniotic sac. This white arrow is yolk sac. And this small white arrow is embryonic disc. Yeah. There was a question asked about the pointer, and the pointer was towards amniotic sac, the sac which contains embryonic disc. So you had to name what is this sac about. This is amniotic sac. This black arrow is amniotic sac and the white arrow is dedicated to yolk sac. Okay. Right. So there is embryonic disc inside. There is embryonic disc inside this amniotic sac. Okay. These two broad arrows are showing, one is yolk sac, that is white arrow, and one is amniotic sac, that is black arrow, big black arrow, big black, okay, arrow I mean to say, big black arrow, yeah. So yes, we are talking about early pregnancy sonography and this is double bleb sign. There is one thing called as double decidual sac sign. Double decidual sac sign, which is also early pregnancy sign where you will see ring inside the ring. If you see ring inside the ring, that's called as double decidual sac sign. Yep. Double decidual sac sign is ring inside ring. If you see a uterus with a very small bubble-like structure inside. That's it, small bubble-like structure. That is called as intradecidual sac sign. Yeah, intradecidual sac sign is the earliest sign which is seen, right? Intradecidual, then double decidual, then double bleb sign. These are the signs of early pregnancy. Okay, right. Next question, next picture is about placenta. Guys, so what you're seeing in this picture, just focus over here, just focus over here. In this picture, what you're seeing is a placenta which is not looking normal. Kya dikh raha hai? What is seen over here? There is a placenta which is looking like English alphabet Q. Yeah, there is a smaller chorionic plate and unutilized ring of decidua basalis. This is called as circumvallate placenta. Circumvallate placenta. Now, circumvallate placenta will have raised membranes all around this small functional placenta, as you can see over here. This is circumvallate because of the raised membranes. Raised placental membranes are there. Okay, that's why it is circumvallate placenta. And if raised membranes are not shown, then the same thing becomes circummarginate placenta. So circummarginate is like brother of circumvallate. Circummarginate is having no raised membrane. So there will be small functional placenta with ring of decidua basalis which is not utilized, but there will be no raised membranes. That's circummarginate placenta. Okay, so here's chorionic plate is smaller than decidual plate. Yeah, chorionic plate is smaller than decidual plate in both the cases, circumvallate and circummarginate. Remember that these two conditions are also called as extrachorial placentae. Yeah, extrachorial. Extrachorial placentae. Okay, right. Circumvallate, circummarginate placentae are known to cause what? See, the functional area is small, that's why there will be chances of IUGR, intrauterine growth restriction. Then there will be a chance of preterm labor. IUGR, then preterm labor. Then there is a chance of fetal distress because of less oxygenation. Yeah. Why preterm labor? Because of less progesterone. Less progesterone. There will be oligohydramnios as well because of less urine output. So all these pathetic things would be seen because of small functional area of placenta. Small functional area of placenta is there. Okay, functional area is small. Let's take another question. Come on guys, tell me, what abnormality are you seeing over here? You are seeing an abnormality where placenta is not having this attachment of umbilical cord. Umbilical cord is ending in the membranes. Cord is ending in the membrane. So this is called as velamentous placenta. Yeah, velamentous placenta. And velamentous placenta can cause vasa previa. Yeah, it is responsible for formation of a condition called vasa previa, where vessels will be lying exactly above internal os. And these vessels are fetal vessels. Yeah, vasa previa type 1 is dedicated to velamentous placenta. And vasa previa type 2 is dedicated to succensurate placenta. Yeah, and the test which is used to detect fetal blood in antepartum hemorrhage. Now let's suppose there is rupture of membrane and there is bleeding coming out from vagina. How will I know that this is baby's blood or mother's blood? That test is used, and that test is called as APT test. Yeah, APT test is used to differentiate fetal blood from maternal blood. But let me tell you that in my clinical practice of 16 years, I have never done APT test because We have sonography in our hospitals. Sonography machine is there. Investigation of choice for Vasa previa is none other than USG Doppler. Nobody does apt test, but MCQs, you should know apt test is a quality test. It will tell us whether the baby blood is baby's blood or mother's blood. And we use alkali for this test. Yeah, this is alkali test, and fetal RBCs and blood are, alkali resistant. This will differentiate baby's blood from mother's blood. Okay, but investigation of choice is USG Doppler, and treatment of choice is cesarean section. Whenever there is Vasa previa, we should do cesarean section. That's the treatment of choice, cesarean section. All right. Yes, one more thing. If there is a dead baby plus Vasa previa, remember, very simple. We are doing cesarean only when the baby is alive. Yeah. Dead baby plus Vasa previa, you can do vaginal delivery. Why not? There is no mechanical obstruction. Yep. There's no mechanical obstruction. Right? Got it? Very clear? Yes. Dead baby plus Vasa previa is equal to vaginal delivery. Alright? Yes. So my dear friends, Vasa previa would require cesarean only if the baby is alive. Only if the baby is alive. Alright? Guys, so next photograph, you'll have to find it in the book. The photograph is about a clinical examination. You can see this clinical examination. Come on guys, everyone, focus on this slide. Look at what is happening over here. Yeah. So, guys and girls, this is a clinical examination, and you're doing something called as bimanual examination. Bimanual examination. Yeah, both hands are used, and you are able to palpate soft isthmus. This is called as Hagar sign. This is called as Hagar sign, soft isthmus. And you can see pregnancy is growing in the upper part, and there is empty lower part of uterus. Hagar sign, the softening of isthmus. Remember, softening of cervix is called as Goodell sign. Softening of cervix is called Goodell sign. Hagar sign is softening of isthmus. It is seen between roughly 6 to 10 weeks. So it is first trimester finding. Obviously, the uterus will be completely occupied by the end of 4 months. Yeah. And yes, there will be no Hagar sign obviously in second trimester. The time period of Hagar sign is just 6 to 10 weeks. All right. Right. So guys, yeah. Somebody has asked about Vasa previa. Remember, Vasa previa, previous slide, Vasa previa plus dead fetus is equal to vaginal delivery. Vasa previa plus alive baby is equal to cesarean section at term. Yeah. And if patient has already had a rupture of membrane, obviously we are not going to wait till term. We will do cesarean section for saving the baby. Okay. All right. So this is about this picture. Next picture. Come on guys. Focus, focus, everyone. What you are seeing over here is an obstetric examination. You can see that there is obstetric examination going on and only one hand is used. This is called as Paulik grip. Also called as Leopold grip number 3. Paulik grip, Leopold grip number 3 is done in third trimester. Yeah, it is not meant for first and second trimester. It is meant for third trimester. And if you find that Paulik grip is empty, then it only means that baby is in transverse lie. Yeah, you already covered this part about examination. You have seen first grip is fundal, second is lateral, third is Paulik grip, and fourth is deep pelvic grip. Yeah, fourth is deep pelvic grip. What if during examination you find more than 2 poles during examination? It only means that there is multifetal pregnancy. More than 2 poles. See, each baby will have 2 poles. Yeah, cephalic pole and podalic pole. If there are more than 2 poles, it only means that you are dealing with multifetal pregnancy. All right. Paulik grip is basically for a diagnosis of what? for diagnosis of presentation. Paulic is for diagnosis of presentation. Okay. Next slide. This is the pelvis, maternal pelvis, but it has heart-shaped inlet. It has acute subpubic angle. Acute subpubic angle. Yeah. And sciatic notch. Sciatic notch is narrow and deep. Yeah, acute subpubic angle. Sciatic notch narrow and deep. Heart-shaped inlet. Heart-shaped inlet is dedicated to android pelvis. Yeah, it has heart-shaped inlet and funnel-shaped cavity. Yeah. Now guys, heart-shaped inlet, funnel-shaped cavity, so it is narrowest pelvis. Yeah, which is the deepest pelvis? Deepest pelvis, anyone? Deepest pelvis is anthropoid pelvis. Most spacious pelvis? Most spacious pelvis is gynecoid pelvis. Yep. Anthropoid pelvis has egg shape. Yeah. Gynecoid is round. Android pelvis has heart-shaped inlet. 20% females have android pelvis. Heart-shaped inlet. Yeah. So girls, remember, if any guy tells you that I love you by my heart, remember, the meaning is something else. Right? Yes. So remember, we, the males, 46XY people, think from our heart. Okay? Take it from me. Right. So guys and girls, android pelvis is narrowest pelvis, heart-shaped inlet, funnel-shaped cavity. It causes prolonged labor. And yes, it causes transverse lie. Okay? Right. So this is about android pelvis. Yeah? Well, there is one more pelvis called as platypeloid pelvis, which is called flat pelvis. Platypeloid is very rare pelvis. Flat pelvis, it is also called rickety pelvis. So if you ever get a question, kidney-shaped inlet, kidney-shaped, then the answer is platypeloid. Kidney-shaped is platypeloid. Remember this thing. Right? Right. Okay. Guys, there is one pelvis called Negli's pelvis where one ala of sacrum would be missing. If there is absence of both the alae, then we say Robert's pelvis. Yeah? Right. So, Negli's pelvis, one ala missing. Robert's pelvis, both the alae would be missing. Yeah? Contracted pelvis. Right. Right. Next. Let's be fast. We all have seen some procedures which are done in the procedures which are done in pregnancy, and those procedures are called as prenatal genetic diagnostic tests. This is one of them. Prenatal genetic diagnostic test where needle is inserted right into the amniotic sac. This is called as amniocentesis. Mark my words. If the needle is ending in placenta, then your answer should change to Corion-Villus sampling. Remember this. If needle ends in amniotic sac, then it is amniocentesis. If it ends in placenta, then it is Corion-Villus sampling. This can be done abdominally. This can be done cervically. But amnio is always done abdominally. Okay. Amniocentesis is not allowed in first trimester. Okay, amniocentesis should not be done in first trimester. Time of doing this is, after 15th week, 16th week, you can do it, but not before 14 weeks at all. So first trimester is a contraindication, right? Risk of abortion is roughly 0.3%. Serious risk of abortion is 1%. Yeah. And if the needle is ending in umbilical cord, then it is called chordocentesis. Cord would be chordocentesis. It is used for treatment of anemia in many cases. Example, RH incompatibility. Yeah. So this is a picture of amniocentesis. This is a picture of amniocentesis. Right? Next picture. Yeah. Okay, somebody has asked, what about both ala absent? Previous picture, one ala missing is Negli's pelvis. Both alae are absent in Robert's pelvis. Robert pelvis. Okay. Next picture, next picture, next picture. Now what you are seeing on the slide is an investigation where fetal heart rate is monitored electronically. Fetal heart rate is monitored electronically and uterine contractions are monitored electronically. And in this picture, uterine contractions are not there. Yeah, uterine contractions are not there. So guys and girls, if uterine contractions are not there, this picture is a picture of non-stress test. Yeah, fetal investigation, non-stress test, NST. Yep, non-stress test. Guys, yaad rakho, remember this thing. In non-stress test, uterine contraction line would be a flat line. And if there is cardiotocography, you will see contraction graph as well. Technically speaking, NST is also a cardiotocography with no contractions. Yep. So we are monitoring fetal heart rate electronically. There should be 2 or more accelerations in 20 to 40 minutes. Yeah. Yeah, risk of abortion. Previous slide, somebody is asking, previous slide, risk of abortion 0.3%. Okay, all right, okay. 2 or more accelerations in 20 to 40 minutes would be required to label NST as reactive NST. NST will be deemed as reactive NST if 2 or more accelerations are found. Acceleration would be defined as increase in heart rate by 15 beats for 15 seconds. 15 beats, 15 seconds would be acceleration. Okay, am I clear? Yes, one more thing. If baby is small baby, less than 32 week size baby, then 10 beats and 10 seconds. 10 beats and 10 seconds. Okay, right. So guys and girls, acceleration is defined as increase in heart rate by 10 beats 10 seconds if baby is less than 32 weeks. This is NST. This is third trimester investigation. This is for high risk pregnancy only. Yeah, this is for high risk pregnancy only. Yeah, high risk pregnancy, not for all pregnancies because it has high false positive. False positive would mean that baby is healthy, but still NST is showing non-reactive pattern. False positive, high false positive, and there is low false negative. Low false negative. Let's say baby is unhealthy. Baby is unhealthy and you are seeing acceleration. That's virtually impossible. Yeah, so low false negative, high false positive in NST, non-stress test. Okay, am I clear about this? Everyone, focus over here. Next slide. Very famous slide, important slide. What is seen in this slide? You are able to see USG Doppler finding. USG Doppler shows systolic flow, diastolic flow. Systolic flow, diastolic flow. Both the flows are seen. So first picture has diastolic flow. Diastolic flow is present. Second picture, unfortunately, diastolic flow is absent. There's no diastolic flow. Yeah. And yes, diastolic flow is reversed. We call it as REDF in the third picture. Yeah. And if you want to know whether baby is healthy or not, please stick to umbilical artery Doppler. Umbilical artery Doppler is for fetoplacental insufficiency. Yeah. Umbilical artery Doppler is for fetoplacental insufficiency. Uterine artery Doppler is for uteroplacental insufficiency. And if you want to check the health of baby, then umbilical artery Doppler is more specific for fetal health. More specific for fetal health. Remember, uterine artery for uteroplacental insufficiency. Umbilical artery for fetoplacental insufficiency. Am I clear? Yeah. So this is a picture of uterine umbilical artery Doppler. See, uterine artery Doppler would also look like the same. It's all about where you have put the probe, right? And yes, umbilical artery is meant for assessing fetal health. You can continue pregnancy if you see diastolic flow, continue pregnancy, you should do LSCS at 34 weeks. You should do LSCS at 34 weeks for absent diastolic flow, and you should do LSCS at 32 weeks for reversal of diastolic flow. We believe in knowing baby's health by umbilical artery Doppler. Yes, middle cerebral artery Doppler is basically meant for assessing fetal anemia, Rh negative topic. Yeah. Next picture, very simple picture. What you are seeing over here is a sonography of complete molar pregnancy. Complete mole, CHM, complete hyridiform mole. Yeah, well, how it is formed? An empty egg will be fertilized by a sperm. Yeah, 23 eggs from the sperm will enter inside and will fertilize this egg. And since there is no maternal chromosome at all, it will double up inside. And the resultant karyotype will be 46XX. Yeah, 46XX is the karyotype of this pregnancy. Is it possible to have 46XY? Very rare. 5 to 10% cases there will be multispermy. Otherwise, the rule is monospermy is by default. Monospermy is the cause of complete mole. Monospermy is the cause. Yeah, monospermy causes complete mole. Very rare would be dispermy causing complete mole. When empty egg gets fertilized by 2 sperms. Yeah, 2 sperms have entered inside. 23X, 23Y. The resultant karyotype would be 46XY, which is very, very rare. Yeah, am I clear about this? Guys and girls, there is no possibility of 46YY because X is necessary for life. X is necessary. Remember, girls, you don't need Y for survival. Yeah, X is sufficient, self-sufficient. Yeah, and remember, guys, you should at least have one X chromosome in your life. Yeah, X is necessary. One X is necessary. Remember this thing, right? So 46YY is not possible. Okay, and what is this sonography called as? Sonography is called as snowstorm appearance. Snowstorm appearance. Okay, right. Snowstorm appearance is seen because of multiple fluid-filled grape-like vesicles. Multiple fluid-filled grape-like vesicles. Those who have one X, please don't lose that X. X is necessary in life. Yeah. Multiple fluid-filled grape-like vesicles. Alright. So guys, the treatment of choice. When you want to treat this condition, you have to do something called as suction and evacuation. Suction and evacuation, you must have seen MVS syringe. Yes, suction and evacuation can be done and you can remove out this pregnancy. Treatment of choice, suction and evacuation. Yes, we do HCG evaluation every week till it becomes negative for 3 weeks. And yes, we follow it with monthly HCG evaluations for the period of 6 months. Surveillance period, 6 months after HCG has become undetectable. Yeah. What about partial mole? Partial mole is totally different. Partial mole has maternal chromosomes. That's why a fetus is there. Yeah. 23X will be there in partial mole. Maternal 23X. And there would be, what should I tell you? Multiple sperms entering inside. I don't want to use this terminology on live, session, but everyone knows, those who have attended my lecture, and if there is multiple sperm entry, what is that called? Yeah, I will not utter that live. All right. Yes, you all know it. Yeah, multiple sperms entering inside. Right. So we will have multispermy, and that's why partial mole is never deployed. Most common karyotype of partial mole is a very dangerous figure called 69. All right, partial mole, triploidy would be there because 2 sperms will be entering inside, and yes, maternal chromosomes would be there. So most common would be 69, XXY, XXX possible. Yeah. Next, Next. What you're seeing over here is cervix, yeah, and speculum and the retractors are there, and yes, somebody is taking stitch all around the cervix in a purse string manner. What is the cerclage called? This is called as McDonald's cerclage. Purse string suture, McDonald's cerclage. Yeah, this is McDonald's cerclage, purse string suture. This is done at portio vaginalis. Which cerclage is done in supravaginal cervix? The answer is Shirodkar's cerclage. Shirodkar's cerclage is done at supravaginal cervix. That's why we need to cut the vagina in order to take the stitch, right? Yeah, this is McDonald's cerclage, right? Suture material should be non-absorbable. Suture material should be non-absorbable. And we use Marceline tape, black silk, yeah, and non-absorbable suture material should be used. And yes, ideal time of surgery is roughly 12 to 14 weeks. Underline 14. Yeah, 12 to 14 weeks. Non-absorbable suture material. Alright. Next. This is what I was talking about. This is the procedure called as suction and evacuation. And this is done with the help of the syringe called as manual vacuum aspiration syringe. MVA syringe. Manual vacuum aspiration syringe. Right? It is used for doing medical termination of pregnancy of first trimester. It cannot be used for second trimester. Yeah, it can be used maximum till 12 weeks. Yeah, not beyond that, right? The capacity of this syringe is 60 ml. Yeah, manual vacuum aspiration syringe, capacity 60 ml. Pressure is 600 to 660 millimeters of mercury. 600 to 660 millimeters of mercury, right? Right. What is the position given? The position given over here is lithotomy position. Yeah. We use paracervical block. We can give additional short general anesthesia as well. Additional short general anesthesia can be used, but paracervical block is important, right? Well, this is about MVA syringe. Next picture. Come on. This is a slide of something called as KB test. Yeah, KB test. Guys and girls, what you are seeing on the slide are fetal RBCs. And you are also seeing some shells over here. These shells are ghost cells. These are maternal RBCs. Yeah. This slide is a test called KB test. Klehor Betke test. Klehor Betke test. Yeah. KB test. This is done in patients who have Rh negative blood group. Yeah. And partner is Rh positive. Rh positive partner. Right? And this test is done in order to know how much fetal blood is there in maternal circulation. It is used to calculate the amount of fetal blood in maternal circulation. Right? Fetal blood in maternal circulation. And 1 ml of fetal blood is neutralized by 10 microgram NTD. Yeah, this test tells us amount of fetal blood in maternal circulation. This test uses the principle that fetal RBCs are acid resistant. Yeah, we use acid and we evaluate fetal RBCs in maternal circulation. Yeah, 1 ml of fetal blood is neutralized by 10 microgram NTD. 50 microgram is needed for first trimester exposure. 300 microgram is needed for second or third trimester exposure. 300 microgram is compulsorily given at 28 weeks. 300 is compulsorily given at 28 weeks. And if there is severe exposure like antepartum hemorrhage or IUFD, we do this test. So KB test is basically to know whether 300 would be insufficient or sufficient. Yeah. So if you are dealing with, let's say, manual removal of placenta, a case where there is manual removal of placenta, so we will do KB test in order to know how much blood has gone into maternal circulation. Let's say 50 ml of fetal blood is there in maternal circulation. We'll have to give 500 microgram of anti-D. Remember, 500 microgram of anti-D. Am I clear? Yes. One more thing. 1 microgram is equal to 5 international unit. 1 microgram is 5 international unit. Okay. This test is basically test which tells us about fetal RBCs in maternal circulation. We take mother's blood, we put acid and we do microscopy. Because of acid, maternal RBCs will undergo hemolysis. But acid will not cause hemolysis of fetal RBCs and you will be able to see these pink colored fetal RBCs. Okay. Right. So 1 microgram NTD is equal to 5 international unit. Yeah. So remember. Maximum dose which can be given per day is 1500 microgram, which is equal to 7500 international unit. Maximum dose is 1500 microgram, which can be given to any patient. Yeah. 500 microgram would be needed for 50 ml of fetal blood in maternal circulation. I was giving an example. If KB test tells you 50 ml blood is there in circulation, you will have to give 500 microgram NTD. Yeah. 1 ml is neutralized by 10 microgram. 50 ml will be neutralized by 500 microgram. Very simple math. Okay. Yes. Next. What you are seeing over here is a procedure called as controlled cord traction. It is called as modified Brandt Andrews method. Modified Brandt Andrews method is the method of controlled cord traction. It's a part of active management of third stage of labor, AMTSL. Active management of third stage of labor. You will have ENT class at 6 p.m. So I still have time, don't worry. Active management of third stage of labor. It prevents inversion of uterus and it prevents postpartum hemorrhage. Basically, active management of third stage of labor is prevention guideline. Yeah, prevention of PPH will be by active management of third stage of labor. Okay, we already discussed that part. Right now, let's jump on to the next slide. What you're seeing over here is a procedure of delivery of the baby with breech presentation. What is wrong about this? I mean, what is so abnormal about this delivery is that the arm of the baby is extended. Generally, the arm of the baby is flexed. Yeah. Here the arm of the baby is extended. So we use the maneuver called as low set. Low set maneuver is used to deliver extended arm. Yeah. Pinard is used for delivering extended leg. Pinard is used for delivering extended leg. Low set is used for delivering extended arm. Yeah. Right. So arm extended, low set. Legs extended, what is called a frank breech presentation. Pinard's method is used. Okay. Right. We have few more maneuvers. We will talk about those things. Look at this. This is a maneuver where baby's head is delivered out. In breech delivery, yes, but the back of the baby is lying posterior. This is called dorso-posterior position. Generally, the back of the baby is anterior. This is called as Prague. Prague maneuver. Yeah, this is called Prague maneuver. It is used when the baby is in dorso-posterior position. See, we have not done anything. Baby was delivering out, buttocks had come out, but the back went posterior, back was posterior. So we have to apply this maneuver called as Prague maneuver. It's not Burns-Marshall maneuver. Burns-Marshall also looks like this, but with Burns-Marshall maneuver, you will see the back anteriorly placed. Yeah, Prague is dorso-posterior, Burns-Marshall is dorso-anterior. Yeah, it is also called as chin to pubis delivery. Prague is also called chin to pubis delivery. Yeah, chin to pubis delivery. Next method. Are you all on track, guys and girls? Hopefully you are on track. Okay. Yeah, Prague. Okay, Prague is done. Let's jump on to the next. You are seeing a maneuver where head is getting delivered out with your help. You are doing something. You are putting your dominant hand below the baby. Non-dominant hand above the baby. Yeah, dominant is below, non-dominant is above, and this is called as modified MSV. Okay, don't write modified, write down MSV. Morris Smelly Wet. Morris Smelly Wet method. Yeah, Morris Smelly Wet method is this method. How to identify this method, how to understand this method? One hand below the baby, one hand above the baby, and you are doing something called as jaw flexion and shoulder traction. Jaw flexion, shoulder traction is MSV. There is a small modification nowadays. It's called as modified MSV, and there is malar flexion nowadays and shoulder traction. Yeah, instead of putting middle finger in the mouth, you are putting the fingers on the cheekbones. Okay, I'm not swearing. Yes, I'm telling you that the cheekbones would be flexed. That's why malar flexion, shoulder traction. That's modification. Yeah, original one was jaw flexion, shoulder traction. Okay, next thing. This is the maneuver where patient is flexing her hip joint. This maneuver is used for shoulder dystocia. In fact, this is the first maneuver to be done. First maneuver to be done in a case of shoulder dystocia. This is called as Mack-Roberts maneuver. Mack-Roberts maneuver. Yeah, it is the first maneuver to treat shoulder dystocia. Yeah, it is the first maneuver to treat shoulder dystocia. Mack-Roberts maneuver. Alright. Yes. Here we will do something called as hyperflexion at hip joint. Hyperflexion at hip joint. Along with that, we add something called suprapubic pressure. Yeah. Mack-Roberts plus suprapubic pressure have success rate of 50%. Yeah. If things don't work out, then we have other names like Wood's method, then Rubin's technique, then Gaskin method, yeah, then removal of posterior arm, which is not labeled anything, yeah, and lastly there is a method called as Zavanelli method, where we push the head into the pelvis and do cesarean section. That's the last method ever applied. Yeah, Zavanelli, push the baby and deliver. Push the baby and deliver by cesarean section. Yeah, Zavanelli method is the last method. What you are seeing over here is Mack-Roberts maneuver. Okay, right. Okay, Mera sir, my head is coming in between. I think I'm about to deliver out. Look. Okay, delivered. Okay, no shoulder dystocia. Right. Okay. Yeah, guys and girls. Next is the picture. It's a picture of uterus which is seen during cesarean section. Yeah, it's a picture of uterus seen during cesarean section, and you are seeing that uterus is not looking pink. It is stained with blood. This is called as cuvulaire. C-O-U-V-E-L-A-I-R-E, cuvular uterus. This is seen in a case of abruptio placenta. Abruption causes cuvular uterus. It is a condition where serosa is stained with blood. Serosa is stained with blood. Yeah, right. It's not an indication of hysterectomy because it's just a finding. Yeah, it is seen most commonly with concealed abruptio placenta, and it's not an indication of hysterectomy. We don't change our treatment protocol based on looking at cuvular uterus. We will treat the patient as we do for a non-cuvular uterus. Okay, so it's not an indication of hysterectomy. Yes, that's true. Antepartum hemorrhage can cause postpartum hemorrhage, and in some postpartum hemorrhages we might have to do hysterectomy, but not for cuvular uterus per se. Okay, right. Next question, next slide, next slide. This is sonography of a baby in sagittal view, and the focus is on the neck region of the baby, this region, and the amount of fluid accumulated in the neck region is evaluated. This sonography is called as NT scan. Nuchal or knuckle, potato, same thing. Translucency. Cuvular uterus. Cuvular uterus is called as cuvular because it is uterine apoplexy. Yeah, cuvular is uterine apoplexy. Okay, right. So this is the scan of nuchal translucency. Fluid is evaluated. Maximum depth is evaluated. It is used for screening Down syndrome, Edwards syndrome. So trisomy evaluation. Yeah, trisomy evaluation. Down syndrome, predominantly Down syndrome. Remember, the critical cutoff is 3 millimeter, and the time of doing this test is 11 weeks to 13 plus 6 weeks. So 11 to 13 plus 6 is the time. Yes, first trimester evaluation. This is first trimester screening. Yeah, first trimester screening, NT scan. In second picture, you are seeing that the fluid accumulation is more than or equal to 3 mm, so it is high risk. So we should send this patient for chorion villus sampling. I told you that in order to know whether the baby is actually suffering from Downs or not, you will have to do prenatal genetic test. And first trimester test is never amniocentesis. It is chorion villus sampling. If you find NT scan positive, you are supposed to do chorion villus sampling if you find NT scan positive. Yeah, got it? Very clear. Yes. So baby should be in sagittal view, right? Right. Next picture. Well, this is a picture of twin pregnancy. 2 sacs, 2 babies are seen, and you are seeing a very thick septum in between. Yeah, the thick septum is there. Thick septum is there in between 2 babies, right, guys and girls? Okay, previous picture, somebody said karyotype. Yeah, chorion villus sampling on NT scan positive, chorion villus sampling. What do we do with that chorion? Karyotype, of course. Karyotype will be the ultimate thing, but how will you get the tissue? By chorion villus sampling. Okay, CVS plus karyotype. What you are seeing over here is a sonography of twin pregnancy, and both the babies are separated by thick septum. This is called as lambda sign, also called as twin peak sign. Yeah, it is seen in dichorionic diamniotic twins, DCDA twins. Yeah, DCDA twins. Rochit is asking, why not double marker? My dear Rochit, remember this thing in our previous slide, when NT scan is told as positive, why are you going for screening test? Understand, double marker, dual marker test is also screening test. Yeah, in first trimester we don't do NT alone. We do first trimester screening called combined screening containing NT plus dual marker. If dual marker is positive, then also we do CVS. If NT is positive, then also you will do CVS. Am I clear? So dual marker is screening, NT is screening. And if anything is positive, we are going to go for a test called chorion villus sampling. Am I clear about this? Yeah. Here I was talking about DCDA twins, dichorionic diamniotic. Thick septum is more than or equal to 2 mm. Yeah, it is made up of 4 layers. You can detect this between 10 to 14 weeks sonography. In between 10 to 14 weeks sonography. Yeah. Yes, this is lambda sign, also called as twin peak sign. Yeah, right. So guys and girls, lambda sign is twin peak sign. It is seen in DCDA. If you see one placenta and you see a thin septum, that's called as T sign. T sign will not have this chorionic tissue in between the two babies. Yeah. So remember, T sign is for monochorionic diamniotic. Monochorionic diamniotic, MCDA. Okay. Next picture. Now this is difficult. You have to understand what is going on over here. They will give you some kind of hint, like there is a scan of adnexa. Otherwise, it's very difficult to know what is going on. Obviously, when we put a probe, we see adnexa. Adnexa means the area near the uterus, and you are seeing near the organs near the uterus. And you are putting Doppler to it, you are seeing increased vascularity. This is called as ring of fire appearance. Ring of fire appearance is seen in ectopic pregnancy and also in a case of corpus luteum of pregnancy. Corpus luteum of pregnancy can also present like this, ring of fire. Yeah. The interesting part is that clinically it's very, very easy to differentiate whether it is ectopic or corpus luteum of pregnancy. Just look at the uterus. If uterus is empty, then ring of fire is ectopic. If uterus has pregnancy, then this ring of fire is corpus luteum of pregnancy. Yeah. You may argue with me that this could be ectopic and there could be pregnancy in uterus called heterotropic ectopic. Believe me, that's very, very rare, 1 in 30,000. And it's seen with IVF pregnancy. So remember, rare things are rarely diagnosed. And for you people, if there is pregnancy in uterus and ring of fire, you should diagnose it as corpus luteum of pregnancy. If there is history of IVF along with it, then you suspect heterotropic ectopic. Yeah, so two differentials, ectopic pregnancy and corpus luteum of pregnancy. Okay, am I clear about this? Yeah, got it? Very clear. Previous slide was of lambda sign. Lambda sign, twin peak sign. Thick septum. Thin septum is seen in MCDA. Thick septum is seen in DCDA. Lambda sign has 4 layers. Thick septum has 4 layers. Thin septum, T sign, 2 layers. Yeah. MCDA, monochorionic diamniotic. Okay. Am I clear about this? Right. So guys, after this, let's talk about another picture. Now, this is the picture where you are seeing fetal heart rate monitoring and you are seeing uterine contractions as well. Yes, this is not NST. I told you NST will have flat contraction line. Here you are seeing contractions. So this is a graph of cardiotocography and you are seeing that the graph is going downwards. Suddenly there is a drop in heart rate. Yeah. Remember this thing, when heart rate falls suddenly, that's a sign of variable deceleration. Yeah. Remember, variable deceleration is a sudden type of deceleration. Dagduk, 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 dhagduk, 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 dagduk, 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 dagduk. So what happened just now? Heart rate went down suddenly, and that happens due to cord compression. So this is the picture of variable deceleration. It is due to cord compression. Yeah. Cord compression. Whenever there is cord compression, we change the position of the patient. We give preferably head low position so that the baby's head doesn't, press the umbilical cord. We do PV examination. Yeah, PV examination to rule out cord prolapse. Yeah, PV examination to rule out cord prolapse. Yeah, and if cord prolapse is ruled out, then we have an opportunity to do amnio infusion, a wonderful procedure to correct variable deceleration. Ultimately, cord is getting compressed, and that's why vagus nerve is getting stimulated, and that's why the heart rate is dropping down suddenly. Yeah, what you're going to do is amnio infusion in labor. Yeah, this procedure called amnioinfusion is only for variable deceleration in labor, right? You don't do amnioinfusion otherwise. Okay, am I clear about this? Yeah. So guys, variable deceleration will always be a sudden deceleration. Early and late decelerations are always gradual deceleration. So the graph will go down gradually, will come up gradually. Okay. The starting point and the lowermost point will be more than or equal to 15 seconds away. Yeah. So early and late are graduals. Variable is sudden. And early will occur with contraction. Late will occur after contraction. Big difference. Yeah. Okay. Omkar, GM site. Okay. Yes. Right. Okay. Where were we? Yes, we were talking about treatment. I said amnioinfusion is only for variable deceleration, not for anything else. Okay. Okay. Fine. Let's talk about, another picture. Shruti is asking, what is head low? Head low position. You will have to give 30-degree tilt, head down, legs up, so that the head of the baby doesn't go into the pelvis. It remains in the abdomen. Yeah. If there is cord prolapse, then also we do the same thing. We give head low position, right? Head is 30-degree down, legs are up, so that the head doesn't go down into pelvis. Down into pelvis. Okay. Down into pelvis. Yeah. All right. So guys, this is a picture of Cusco's speculum. This is a picture of Cusco's speculum. It is self-retaining speculum. It is used to visualize the cervix, the vagina. Yeah, Cusco's speculum is self-retaining speculum. Yes, I think everyone knows early deceleration is because of head compression. Late deceleration is due to uteroplacental insufficiency. Okay, fine. So Cusco's is self-retaining speculum. What is this tubular structure over here? This is a light, it's a canal for light source. Yeah, light source. And you can adjust the distance between the two blades with the help of these screws over here. Yeah, screws will be able to adjust the distance and the angulation. Okay, this is Cusco's speculum, generally used for doing procedures, diagnostic therapeutic procedures on cervix and vagina. Okay, all right. In your hospitals, you must have seen sim speculum, because sim speculum requires assistant, and your hospitals are full of resident doctors, aka assistants. Okay, all right. Yes, so we generally use Sims and Cusco speculum. What you are seeing over here? Next slide. Come on. This is a picture of episiotomy Caesar. Okay, plural. Episiotomy Caesars. Angulation. Why is there angulation in between the handle and the blades? I mean, there is angulation between the blades and the shaft and the handle over here. This is for better field of vision. Angulation is equal to better field of vision. Okay. This episiotomy surgery is ideally done at the time of crowning of head. Yeah, crowning of head. And why is there guard over here? Guard is for avoiding injury. You should not become the first barber of the baby. Yeah, so avoiding injury. Yeah. Narrow blade is used to cut vagina, and broad blade is used for cutting the perineum. By the way, episiotomy is iatrogenic second-degree perineal tear. We cut perineal muscles. We cut vaginal mucosa. We cut perineal skin. So it is iatrogenic second-degree perineal tear. Yeah. And routine episiotomy is outdated. Nowadays, we don't give episiotomy routinely to all patients. We give only in certain indications. Even primi gravida is not an indication of episiotomy. Okay. Am I clear about this? Okay. Right. Next picture is about uterus and cesarean section going on. You can see an opening over here, and a suturing technique is going on. This is called as B-Lynch suture. This is called B-Lynch suture. Yeah. It is used for treatment of postpartum hemorrhage. This is a technique for compressing the uterus. Suture material is absorbable suture. So chromic catgut number 2, not 20. Chromic catgut number 2 is used. Somebody has asked what is crowning. Crowning is when the biparietal diameter stretches the vulva and it doesn't go back. That's called crowning of head. That's the ideal time of episiotomy. Okay. Well, next. Okay. After this, next question. Next question is about gynecology. What you are seeing on the slide is a picture of ovary. Okay, that's a hint. Ovary and picture. You are seeing a picture of ovary, and you are seeing that there are multiple small follicles. Multiple small follicles are there. If you see multiple small follicles, you all know that this is a picture of PCOS, polycystic ovarian syndrome. And if you are seeing the follicles are arranged in periphery, then it is called as necklace. Necklace of pearls appearance. No, this is not OHSS picture. OHSS picture will have a distorted ovarian surface like this with very, very large multiple follicles. Multiple small follicle would be PCOS. Multiple large follicles would be OHSS. We have photograph of OHSS as well. Yeah, volume of ovary in PCOS is more than or equal to 10 cc. In PCOS, volume of ovary more than or equal to 10 cc. Yeah. I will show you a picture of OHSS later on. For time being, you remember multiple small follicles, PCOS, the structure of ovary will be retained. Kidney shaped structure of ovary. You must have seen a picture of ovary, kidney shaped. Yeah. But if it is distorted because of multiple large follicles, that's a picture of ovarian hyperstimulation syndrome. Sundar has asked ideal time of episiotomy in breech. Breech doesn't have crowning of head. Ideal time of episiotomy in breech is climbing of breech. Climbing. Yeah. When buttocks are visible and the diameter called intertrochanteric diameter stretches the vulva, that's called as climbing of breech. Okay. Crowning of head, climbing of breech. That's the time of episiotomy. Okay. Well, after you have written this, let's look at another picture. I said volume of ovary is more than or equal to 10 cc in PCOS. Everyone on track? Yes. Right. Okay. Somebody has requested we should drink water. AC is very fast. I would like a catheter as well. Where is my catheter? Okay, ignore. Yeah. So guys, let's talk about another picture. This is the picture of something called as hysteroscopy. You are seeing a central picture of a normal hysteroscopy. Yeah, normal uterine cavity is seen in this picture. Yeah, this procedure is called hysteroscopy. Yeah, hysteroscopy. And what you are seeing in other pictures, you are seeing picture of intrauterine adhesions, Asherman syndrome, intrauterine adhesions. Highest risk of Asherman syndrome is with postpartum curettage. Yeah, intrauterine adhesions, Asherman syndrome. Other pictures show adhesions inside. Adhesions. Yeah. Highest risk postpartum curettage, and most common cause is dilatation and curettage, DNC. Yeah, so gynecologist is the culprit of Asherman syndrome because DNC is done. Yeah, treatment of choice is obviously hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis followed by pediatric Foley's insertion. Pediatric Foley's insertion would be done in order to keep the walls separate from each other. Yeah, pediatric Foley's insertion followed by estrogen supplement. Estrogen is epithelializing hormone. The wall is made by estrogen. The wall is cemented by progesterone. I always say this. If you want to make the wall, bricks are required. Breaking phase is estrogenic phase. Estrogen causes proliferation and it leads to growth of normal endometrium. And if things don't work out, we still have a therapy called stem cell therapy. Yeah, Asherman syndrome can be treated by SOS, stem cell therapy. Stem cell therapy is used. And if patient is not becoming pregnant even after this, then we have surrogacy. Yeah, surrogacy for infertility treatment if things don't work out. Okay, next picture. Next picture is a picture of hysterosalpingography. Hysterosalpingography. Yeah, HSG. And this picture is having rigid tubes like this and distended ampulla. Rigid tube and distended ampulla. This is the picture of golf club appearance. And you are seeing this picture of irregular uterine cavity, filling defects. Yeah, filling defect. So cobweb-like appearance is there. This is Asherman syndrome, cobweb appearance. And golf club appearance is seen because of distended ampulla. Yeah, this picture, these pictures are seen due to tuberculosis. Yeah, tuberculosis causes all these damages. Tuberculosis, right? Most common contrast used is water soluble, iodine based contrast. Yeah, water soluble, iodine based contrast. What is the treatment for it? Asherman, I told you, hysteroscopic adhesiolysis followed by pediatric Foley's followed by estrogen. Estrogen causes proliferation. The bricking phase is by estrogen and cementing phase is by progesterone. We are giving estrogen supplement in Asherman syndrome treatment. Yep. Most common water soluble, most common contrast is water soluble iodine based contrast. It is done after menses. Obviously, you don't do this during menses. You don't want retrograde menstruation and then endometriosis. And it is done before mid-cycle. Yeah. So guys, after menses, before mid-cycle, so we have a window of day 8 to day 13. We can do this. Roughly done on 9th, 10th day. Yeah, it can be done on 8th day as well. This is hysterosalpingography. Yeah. Water soluble iodine based contrast. Why pediatric Foley's? Because this is not bladder. Yeah, this is uterus. Bladder has massive capacity. Uterus has intrauterine volume of 10 cc. Yeah, we don't want to put adult catheter and then distend it with adult catheter. It will slip out. Yeah, you want to put a small catheter inside pediatric Foley's catheter and distend so that it remains inside. Okay, am I clear about this? That's why pediatric Foley's. Okay, right. This is the picture. Now, madam has already covered this condition. It is called as bacterial vaginosis. I'm covering the slides. So this is the picture of. This is a picture of what? This is a picture of. This is a microscopic picture of clue cells. Yeah. This is the picture of clue cells. Vaginal epithelial cells with bacteria attached to the surface. Gardnerella vaginalis, you know this. Madam has already talked about it. Vaginal epithelial cells with irregular margins because of the organism attached on the surface. And you already know that 20% cells should be clue cells. Yeah. This is a microscopy of clue cells. 20% cells should be clue cells. To diagnose bacterial vaginosis, most common cause is Gardnerella vaginalis. Drug of choice is metronidazole. We have already talked about it. Madam has already talked about it. Okay. This is bacterial vaginosis. Next picture. This is the picture which was asked. That patient, 27 years old girl, has come with history of vaginal discharge. They did not mention about the type of discharge. They did not mention anything about itching present or not. They just mentioned that patient has vaginal discharge and wet mount shows this. So what is your diagnosis? This is the picture of pseudohyphae. which means you will see filaments and spores, and this is seen in candidiasis. Drug of choice is fluconazole, and you know the NACOS kit which is used in these patients would be kit number 2. We have already covered. Madam has already covered this. Yeah, so this is a slide of pseudohyphae seen in candidiasis, and this is a slide of bacterial vaginosis with vaginal epithelial cells becoming clue cells. Okay, all right. Next slide is again about a picture of a vaginal discharge seen in microscopy, and you are seeing the actual organism which is looking like a leaf and has 4 flagellae over here, undulating membrane over here. This is a microscopy showing trichomonas. Yellowish green frothy foul smelling discharge is there. pH is more than 4.5. The only vaginal discharge, infectious vaginal discharge where pH is less than 4.5 is candidiasis. You know this. Drug of choice, protozoal drug of choice. What is the drug of choice? Metronidazole. Partner should be treated. Partner treatment is done compulsorily. If you don't treat the partner, then they will play ping pong. Yeah, they will give and take. I'm talking about infection. Yeah, partner treatment is compulsory. Partner should also be treated by metronidazole. Okay, right. So, my dear friends, this is about trichomonas. Okay, next picture. These are sonographies showing dash, dash and dash respectively. This is the first picture, this is the second picture, this is the third picture. What you are seeing over here is middle picture showing triple lined endometrium. Triple line endometrium. Trilaminar triple line endometrium is seen in proliferative phase. Why it is seen as triple line endometrium? Because upper white line is zona basalis, lower white line is zona basalis of posterior wall, and middle white line is zona compacta. Yeah, the black area in between these 3 lines would be zona spongiosa. So this is a picture of triple line endometrium, proliferative phase endometrium, estrogenic endometrium. Yeah. And the first picture, what you are seeing over here is a single line endometrium. Single line is menstrual phase. Yeah, single line is menstrual phase endometrium. The zona functionalis is out of the body. There is no zona spongiosa, no zona compacta, only zona basalis is there. That's menstrual phase. This single line is zona basalis line, ZB. Yeah, and you are seeing a thickened endometrium over here with mixed echogenicity, and if you put Doppler, you will see increased vascularity as well. This is secretory phase. So the third picture is secretory phase. Hormone responsible for secretion is none other than progesterone. Yeah, progesterone causes secretory changes. All right. I repeat, single line endometrium, zona basalis. It is seen after menstruation. Yeah, once the endometrium is shed off, you will see a single line endometrium. So you do it on day 5, day 6, you will see a single line endometrium. If you do it on day 12, day 13, you will see a triple line endometrium. If you do it on day 22, you will see a thickened endometrium with increased vascularity. Okay? Right. Okay. Next picture. This picture is about the test, which is done in lithotomy position with a cotton swab, and this test is used to diagnose something called as stress urinary incontinence. Yeah, SUI. This is called as Q-tip, cotton swab test. Q-tip cotton swab test. This is done in order to know bladder neck hypermobility. Yeah, patient will be in lithotomy position. Yeah, imagine I am in lithotomy position and you are facing the vagina of the patient and you are putting a cotton swab. Do you want the bladder to be empty or full? You want the bladder to be what? Full, empty, what? The bladder should be empty. Believe me, based on true stories, bladder should never be full. If you put a cotton swab and tell her, madam, push, madam, cough, madam, sneeze, whatever you want to do, increase your abdominal pressure, there'll be a spurt of urine on your face. Okay? Don't want to do that, right? It should be done with an empty bladder. Yeah? Yes. You should bring an umbrella if you are doing it with full bladder. It has to be done with empty bladder, in empty bladder. Okay, based on true stories. Been there, done that. Okay, I still remember. Okay, so it is used to diagnose stress urinary incontinence. Used to diagnose stress urinary incontinence. Yeah. Most common treatment for this condition in picture B, where you will see that movement is more than or equal to 30 degrees. Yeah, movement is more than or equal to 30 degrees. That means SUI is there. The treatment is mid-urethral tape like TOT, like TVT, transobturator tape, tension-free vaginal tape. Yeah. Yes, gynecologists have faced it all, tested it all. Yeah, pathetic. Ignore. Yeah. Be gynecologist, be brave. Yeah. Okay. Right. Let's talk about something else now. Next thing is about an intrauterine device. This is intrauterine device called as Gynefix. Gynefix is 4th generation intrauterine device. Yeah, 4th generation intrauterine device, Gynefix, and this has copper beads. Why it is called 4th generation? Because it is frameless, not shameless, frameless. Yeah, right. So guys, Gynefix, 4th generation frameless intrauterine device. There is no chance of perforation in this intrauterine device. Yeah. Okay. Yeah. So there's no chance of perforation because there's no frame to it. Right. It's just attached to the fundus and it will remain in the body and it will do the business of, it will prevent something called as implantation, and copper is spermicidal. You know that. Yeah. Next. Wonderful intrauterine device coming up. This is a device called as levonorgestrel intrauterine device, LNG IUD. It has a cylinder which contains levonorgestrel. Generally, we use 52 milligram LNG device, Mirena, however you pronounce, same thing. Yeah, this is intrauterine device called Mirena. It contains 52 milligram of levonorgestrel. And it is a 3rd generation intrauterine device. Remember, first generation is non-medicated. 2nd generation is copper containing. 3rd generation is medicated. Like this, LNG is 3rd generation. 4th generation is frameless. Even though it is copper containing, but it is frameless. That's why it is 4th generation. 4th generation is frameless. Yeah. It works for how many years? It works for 7 years as contraceptive and 5 years as treatment of heavy menstrual bleeding. Yes, that's true. 7 years as contraceptive and 5 years. 7 years as contraceptive and 5 years as treatment of heavy menstrual bleeding. This is 3rd generation. I told you 1st generation is which is non-medicated. That's Lippy's loop is 1st generation. Yeah, Grafenberg's ring. Yeah, Ota ring. Those were non-medicated. Those were used in past, not used nowadays. 2nd generation is copper containing. Copper T380A is a classical example of 2nd generation. Yeah. 3rd generation is hormone containing. 3rd generation is levonorgestrel. Yeah. 4th generation is frameless. Gynefix is 4th generation. Okay. Am I clear? Yes. First non-medicated. 2nd is copper. 3rd is hormone. 4th is frameless. Okay. Am I clear? So this is containing progesterone. It should not be used in patients who have breast carcinoma or past history of breast carcinoma. Generally, that's the contraindication. Otherwise, there is no specific contraindication. Yeah. So this is intrauterine device called Mirena. Is heavy menstrual bleeding a contraindication or indication? Indication for Mirena, contraindication for copper T. Yeah, heavy menstrual bleeding. Okay. Am I clear? Right. Those who are thinking, why am I going slow? Guys, remember, I am completing everything till 6 o'clock. That's the time. So don't worry. I will complete everything till 6 o'clock. That's the scheduled time. Yeah, I know. We are running slightly slow, but late, but that's okay. Yeah, we have to cover all the slides. Okay, so don't worry, everything will be covered. We are covering everything. And yes, next picture is a very famous picture, commonly asked. This is a cut section of dermoid cyst. Yeah, dermoid cyst, also called as benign cystic teratoma, mature teratoma, benign cystic teratoma. Yeah, most common germ cell tumor. Yeah, it is most common germ cell tumor, and it is most common ovarian tumor in reproductive age. Most common germ cell tumor, most common ovarian tumor in reproductive age. Yeah, and this person who is laughing at you is not a person. This is dermoid cyst cut open. You can see teeth as well. And in sonography, we see Rokitansky protuberance. Madam has already told you about this. Rokitansky. Yep. Some people want fast, some people want slow. I understand that everyone has different demands. Yes, going fast is dangerous to life. We have to go slow, enjoy the process. And I'm talking about studies, nothing else. Yeah, you can understand everything. Okay, right. So this is about dermoid cyst, and dermoid cyst is most common germ cell tumor, right? Right. Next picture. What you are seeing on the slide? Yeah, those who are telling, sir, fast. Come on, sir, come on. What are you talking about? I will go slow. I always go slow. Yeah, okay, whatever. So next picture is about a picture of a surgery done through obturator approach, and this is a tape which is put below the urethra, above vagina. This is called as transobturator tape. Transobturator tape. Yeah, it is done for SUI. Just now we have covered. If it is too tight, if you're, pressed it too tight and then applied a strong pressure on both sides of obturator foramen, understand this thing, that this is going to cause urethral obstruction, and then patient will have urinary retention. Okay, so guys and girls, remember that there is SUI procedure which is done for the SUI surgery called as TOT, which is done through vaginal route, and the tape is put through obturator foramen. If it is too tight, it causes urinary retention. Yeah, okay. Yeah, I just turned 40. तुम लोग बोलोगे सर को 40 पे ठरक चढ़ी है. नहीं, पढ़ाई कर रहे हैं हम लोग. Yeah, we are studying. Ignore those who have not understood this joke. Ignore. Okay, right. Then what you are seeing on the slide is about a picture which is an instrument which is used in gynecological surgery. Can anyone tell me what's the name of this instrument? Interesting thing is that there are two rings on each side. So total 4 rings are there. Yeah, right. 4 rings are there. 2 rings on each side. This is called as Boni's myomectomy clamp. See, when you are doing myomectomy, you want to remove the fibroid from uterus. You want to cut off the blood supply of uterus temporarily. So this instrument will be applied on the uterine artery, sliding from the fundus and including the round ligaments, so that it doesn't actually injure the uterine artery. Round ligament will act as shock absorber. And this instrument will be placed on uterine arteries at the level of isthmus. And yes, there is blood supply from ovarian artery as well. For that, sponge holders are used. Yeah, so we have to block the blood supply with the help of Boni's myomectomy clamp and sponge holders. Okay, it is used in surgery called as myomectomy, and it clamps the uterine artery temporarily. 20 minutes on, 10 minutes off. That's a procedure. That's the time period actually. 20 and 10. 20, 10. So 20 minutes we apply, 10 minutes we release. We don't want permanent obstruction, so we apply for 20 minutes, we leave for 10 minutes. Boni's myomectomy clamp. Okay, right. We are going to finish off very fast, so don't worry. We are on track. We are just about to finish in 15 minutes. So push, guys, push. I know you have done well. I know you are sitting since morning. I know you are doing really well, but take a deep breath. Come in lithotomy position and then push. Okay, you are doing well. Come on. Okay, next picture. This is actually a picture. On the left hand side is a normal uterus. On the right hand side, something is there inside uterus. Yeah, this is the uterus containing fibroid. Now, fibroid inside the uterus could be pedunculated or could be non-pedunculated. Yeah, FIGO 0 is pedunculated fibroid, 1 and 2 are non-pedunculated submucous fibroids. So if most of the fibroid is in the cavity, it is called FIGO number 1. FIGO number 1, most of the fibroid is in the cavity. Yeah, and FIGO number 2 is that less than 50% will be in the cavity, more than 50% will be in the musculature. Okay, right. So guys, uterus contains fibroid of type 1, FIGO, right? This investigation is called as, so when you're putting saline inside uterus and doing sonography, it is called as saline infused sonography. Yeah. Saline infused sonography. Yes, my dear friends. SIS. Okay. Somebody is asking me to wish Dr. Priyadashini happy birthday. Very nice. Happy birthday. Happy birthday. Okay. So guys, the investigation of choice, investigation over here is saline infused sonography, and treatment of choice is hysteroscopic myomectomy. Hysteroscopic myomectomy. Yep. This is treatment of choice for 0 or 1 fibroid. Remember, FIGO 0 or FIGO 1 plus any symptom plus any age group is equal to hysteroscopic myomectomy. Go inside, remove the fibroid, come out. Yeah. Right. So guys, this is about saline infused sonography. Next picture. Next picture is about a uterus. It is uterus showing bands of hypoechoic areas. These bands are not actually, the areas filled with fluid, but there are pockets of fluid over here, and because of these pockets, shadows are created behind the pockets. This picture is called as Venetian blinds appearance. It is seen in adenomyosis. Yeah, Venetian blinds appearance. You can very well see there are bands, hypoechoic bands created because of blood collection in the uterus. Adenomyosis. Yeah, Venetian blinds appearance. It's seen more common in multiparous patient. Remember, adenomyosis, multiparous, endometriosis, nulliparous. Treatment options. See, this condition is most commonly seen in 40 plus age groups. So treatment options are hysterectomy, and if patient is not ready for hysterectomy, then we can opt for LNG IUD, levonorgestrel intrauterine device. Remember, progesterone is also called anti-proliferative hormone. Progesterone is anti-proliferative hormone. And continuous progesteronic exposure will cause endometrial atrophy. Even atrophy of adenomyosis would be there. Yeah. What's the most common symptom of adenomyosis? Menorrhagia. Most common symptom is menorrhagia. Remember this thing. That's why Mirena will be useful, because continuous progesterone causes endometrial atrophy. Remember this thing. Okay. So this is a picture of adenomyosis with Venetian blinds appearance. All right. Yes. Happy birthday to everyone who has birthday today. Leave me alone. Okay. Yeah. All the best. All the best. Yeah. Love you. Love you. Yeah. Okay. Yeah. Okay. Right. Next picture. Next picture. Okay. Where are we? We are talking about a picture where somebody is doing tubal ligation surgery, where a hole is created in mesosalpinx, and then you are ligating the fallopian tube at two ends, yeah, and then you are obviously cutting the part of fallopian tube, and you are rotating the medial portion and burying the medial portion inside the uterus. Uterus is there, medial portion is buried inside the uterus like this. This is called as Ewing method of tubal ligation. Failure rate is nearly 0. Yeah, this is Ewing method. There is a method called Uchida, however you pronounce, where medial end, imagine me as fallopian tube, uterus, and my hands as fallopian tube. Yeah, if you open the serosa, ligate and cut the tubes, and bury the medial stump with the same tubal serosa, the medial stump will get buried under tubal serosa. That's called as Uchida method. Yeah, Japanese method, Uchida. Yeah, that method is having 0 failure rate. Okay, am I clear? So least failure rate, obviously 0 is like 0. So guys, least failure rate would be Uchida method, 0 failure rate. Yeah, there's no chance of failure. This is sterilization, right? Anyone with this answer? Which is the contraceptive with 0 failure rate? Which is the contraceptive with 0 failure rate? Tell me. Those who are exam going, those who are non-exam going should know this. The contraceptive with 0 failure rate. Does anyone know? Hint, there is no MCQ in this. Tell me. Contraceptive with 0 failure rate. I'll give you hint. It is oral. Okay. There was no MCQ, by the way. Those who understood, great. Those who did not understand, go and see Pogo. Channel number 423, Tata Sky. Bye-bye. Yeah. Next slide. Next slide. Yeah. Okay. Those who understood, great. Okay. Next slide. Some will get confused. Ayla, esophagus. Yeah, whatever. Okay. So guys and girls, next slide is about an investigation called HSG, and you are seeing banana shaped uterus. Yeah, this is banana shaped uterus, unilateral, one-sided banana shaped uterus. Yeah, this is HSG showing unicornuate uterus. Yeah, unicornuate uterus, banana shaped uterus. Ek to banana or uterus, bad combination, right? Banana, oh, ignore. Yeah, whatever. So banana shaped uterus is unicornuate uterus. It causes, what will it cause? It will cause recurrent pregnancy losses, recurrent preterm labors, recurrent breach. Yeah, recurrent preterm labors, recurrent breach, recurrent pregnancy losses. Yeah, these are the things. Infertility is not caused by this, not at all. Can it cause endometriosis? Yes, because of something called rudimentary horn, there is a chance of endometriosis. If there is a rudimentary horn, obviously you can't see rudimentary horn over here because it might not be there here. There may or may not be rudimentary horn, right? Plus one more thing, there cannot be transverse lie in this case. Yeah, transverse lie is impossible. Apply your logic. How can transverse lie be there? Breach can be there, but transverse lie is not there. Yeah. So it is treated by cervical cerclage. Somebody has asked, sir, आपको बनाना से क्या याद आता है? तुझे बनाना याद आता है. Okay. बनाता हो तुझे. Yeah. Okay. So, yes, the tube is patent over here. How do you know that tube is patent? You can see the spillage. Spillage is there. And that's why tube can be said as patent. If there is no spillage, there will be accumulation of fluid over there or contrast over there. Okay, right. It is associated with anomaly of renal system. Remember this thing. It is associated with anomaly of renal system. Okay. Remember, genito and urinary are brothers and sisters. So it is associated with anomaly of renal system. Okay, guys and girls. After this, next slide is again about sonography of uterus containing a mass inside uterus. No, this is not saline infused sonography. There is no saline into it. But there is a Doppler. And the Doppler is showing one vessel going right up to the central part and then giving blood to the whole mass. This is the Doppler showing which sign? This is the Doppler showing, yes, what is the sign called as? Feeder vessel sign. Feeder vessel sign, because there is one artery going right into the mass of the polyp and then giving blood to the whole polyp. It's a marker of uterine polyp. And treatment is hysteroscopic polypectomy. Hysteroscopic polypectomy. That's the right answer for polyp which is causing any symptom to the patient. How to identify saline infused sonography? Hint, saline. Pani lagta hai kala. In English, water looks black in color in sonography. And you will be able to see black color fluid around that mass. Yeah, there is no such fluid accumulation, fluid collection in the cavity. You can very well see that there is no such cavity filled with normal saline or black color fluid. Yeah, right. So guys, this is hysteroscopic polypectomy. Okay, hysteroscopic. This is treated by hysteroscopic polypectomy. Okay, next picture. What you are seeing on the slide is a procedure going on. Obviously, it's a dummy pelvis, and the procedure which is going on is introduction of this small, thin, slender Pippel aspirator. Yeah, this is Pippel aspirator. Somebody is asking why cerclage in unicornuate uterus. Cervix is made up of two Mullerian ducts, and if one Mullerian duct is missing, the cervix capacity would be affected. And the job of cervix is to hold the pregnancy. You will have to take a stitch in order to avoid abortions. Okay. Well, let's talk about Pippel aspirator. This is an instrument which is introduced inside uterus. This is called as office endometrial aspiration. Office endometrial aspiration or biopsy is done by Pippel aspirator. You just put it inside and aspirate out the cells. You will see nucleocytoplasmic ratio and you will get an idea whether there is cancer or not. It is in fact screening test for endometrial cancer. Screening test for endometrial cancer. Yeah, Pippel aspirator is used for doing office endometrial aspiration. It is done in OPD to screen out endometrial cancer. Confirmatory test is hysteroscopic endocervical endometrial biopsy, also called as fractional curettage. Hysteroscopic fractional curettage. Yeah, and there's no need of anesthesia. There is no need of cervical dilatation for doing this procedure. Yeah, this is Pippel aspirator. Okay, okay, right. Next. Okay, this is very famous slide. This was asked recently as well. This is actually an ovarian tumor with eosinophilic central material in this mass. What is this material of? What is this picture of? This is histopathological picture of which ovarian tumor? Come on, tell me. Fast. This is ovarian tumor called as yolk sac tumor. And this is Schiller dual body. Central eosinophilic material. Schiller dual body. Yeah? Schiller dual body. It is seen in yolk sac tumor. Seen in yolk sac tumor, Schiller dual body. Tumor marker, we have covered this. Madam has already covered this. Alpha fetoprotein, one line answer. Tumor marker is alpha fetoprotein. There are other non-specific, but alpha fetoprotein is the most important tumor marker of this tumor. Okay. Next slide. This is histopathology of an ovarian tumor, and you are seeing follicle-like arrangements of cells. You are seeing follicle-like arrangements of cells. Anyone with the answer? What is this picture of? Hint, the tumor marker is inhibin. Inhibin is produced by granulosa cell. This is Cole-Exner body. Call Exner body seen in granulosa cell tumor. Tumor marker is inhibin. It is most common sex cord stromal tumor. Most common sex cord stromal tumor. Okay, Call Exner bodies are seen. This is next picture of an ovarian tumor, which is actually not an ovarian tumor. It has come from somewhere else. The cells of these ovarian tumors are pushed into the periphery. This is called as signet ring cell appearance. Histopathology of ovarian tumor showing signet ring cell appearance. Most common primary site is pylorus of stomach. Yeah, this is picture of Krukenberg. Krukenberg tumor. Most common mode of spread is. Most common mode of spread is. Yes, anyone. Most common mode of spread is lymphatic. Then transcelomic. Yeah. Yeah. So this is about Krukenberg tumor. Okay. Am I clear? Yeah. So this is about Krukenberg tumor. Then this is the picture of ovarian hyperstimulation syndrome. What I taught you. If you see multiple large follicles, ovary will have a distorted appearance with multiple large follicles. As you can see, ovary has a distorted appearance over here. Multiple large follicles. Okay. This is a different picture than PCOS picture. This is a picture of ovarian hyperstimulation syndrome. Here it is seen with treatment of gonadotropins. It is seen with the treatment of gonadotropins. Highest risk of this condition is with injection HCG. HCG is the culprit. Sometimes what happens, patient becomes pregnant, and because of pregnancy HCG, there can be OHSS, also called a late onset OHSS. So remember, HCG is the culprit. It can cause hyperstimulation. Yeah. There is increased vascular permeability due to vascular endothelial growth factor. VEGF is highly raised. Yeah. VEGF is highly raised. I will again tell you, multiple large follicles, OHSS. Multiple small follicles would be PCOS. If you see distorted anatomy of ovary, you are talking about OHSS. If you are seeing multiple small follicles arranged anywhere, but then not distorting the contour of ovary, then it is PCOS picture. Yeah. How to find ovary is distorted? Obviously, when you are seeing this picture, see, when you are seeing this picture, you are seeing multiple large follicles. Multiple large follicles. This is because of HCG and other gonadotropins. Yeah. This is due to increased VEGF, and yes, that's why we give bromocriptine, cabergoline, because those are anti-VEGFs. Okay. Am I clear about this? Yeah. So the next picture coming up is this picture, where you're seeing a furning pattern. This is cervical mucus furning. There's a concept that cervical mucus has salts, and these salts, when seen under microscopy, will be seen as furning, will be seen as having a furning pattern. Yeah. So this is cervical mucus furning pattern. Yeah. So concept is that estrogen is responsible for bringing salts in cervical mucus. So estrogen brings furning pattern. Estrogen causes furning, and this picture is seen from 8th to 18th day of cycle. Right? This is cervical mucus furning. Microscopy will reveal furning. And if you see after 18th day, progesterone will be predominant. And progesteronic phase will have no salts. Salts will get dissolved. So there will be no furning. So if any patient has furning even beyond 18th day, we would say that patient has no progesteronic activity. And this is possible only when there is an ovulatory cycle. So the question is, this is a picture of microscopy of cervical mucus on day 22. This picture shows what pattern? As you can see, this is a furning pattern. It is due to the presence of salts in cervical mucus. This is due to the hormone called estrogen. Estrogen works and brings cervical salts in cervical mucus, right? Then patient would be declared as a case of anovulatory cycle, because on day 22 we expect that furning should not be there. So this is one way of diagnosing anovulatory cycle. Whether patient has ovulated or not will be understood by doing this test, cervical mucus assessment. Okay. Yes, one more thing about cervical mucus. If it is stretchable mucus beyond 10 centimeter, then we say estrogen is predominant. If the stretchability is lost, then we say progesterone is predominant. Okay. So stretchability is a marker of estrogen. Beyond 18th day, if it is stretchable, we would say that patient has no progesteronic activity. So she will be anovulatory. Okay. This is about furning pattern. Next question. This is a picture of keyhole sign. So this is a sonography showing keyhole sign. Why is this seen in sonography? This is seen in sonography because of obstruction to the urethral opening. So there is posterior urethral valve. Posterior urethral valve. That's why urine will get accumulated in the bladder and it will not be able to come out. Yeah, that's why you are seeing a keyhole sign. So bladder is over distended, proximal urethra is over distended, and this is keyhole sign, right? Yeah, it is associated with which disorder of amniotic fluid? So when urine cannot come out, it will not be there in amniotic sac. So it is associated with oligohydramnios. Okay. Then the treatment is laser ablation. So this is a fetal surgery where we go inside, we use laser and we cut off this obstruction and we bring the urine out by laser ablation. Okay. So we will fulgurate the posterior urethral valve and the urine will be able to come out. Okay. So this is about posterior urethral valve keyhole sign. Now this is the picture of DASH test. Obviously this is the picture of urine pregnancy test. Why do I say so? Because HCG is written over here. This is HCG evaluation test. Yeah. Is it positive or negative? It is positive. Though the line is very faint, but we will declare it as positive. Okay. If it was negative, only one line, control line would have been seen. Is it quantity test or a quality test? It's a quality test. Yeah. It will tell us whether patient is pregnant or not. Okay. If HCG is there or not. Yeah. Quality test of HCG. Okay. Sensitivity is 10 to 20 international unit per liter. See, HCG comes on day 8 of fertilization. This is due to implantation. And HCG will be detectable by UPT test, urine pregnancy test, roughly day 15 of fertilization. That means day 1 of missed period. UPT will be positive. Okay. It is two-sided sandwich immunoassay test. Yeah, two-sided sandwich immunoassay test. And sometimes it is negative, but patient is pregnant. So it is positive. I mean, it's having false negative scenario in early pregnancy. When the value is less than this, then there will be negative test. False negative in early pregnancy. This is about HCG, two-sided sandwich immunoassay test. Next picture. This is a baby born with dash genitalia. Is it male genitalia? Is it female genitalia? I would say no. It is ambiguous genitalia case. Ambiguous genitalia. Yeah, we cannot identify the gender just by looking at the genitalia. Yeah, ambiguous. Neither here nor there. Yeah. So the most common cause of this condition is actually congenital adrenal hyperplasia, CAH. CAH is an enzyme defect and it is responsible for androgen excess in female babies, female embryos, and that's why this picture would be seen. Ambiguous pattern of external genitalia. CAH is also called female intersex condition. Also called female pseudo-hermaphrodite condition. Yeah. Baby is genetically female but born with male external genitalia. Most common enzyme deficiency is 21 hydroxylase. Most common enzyme deficiency is 21 hydroxylase. Lifelong steroid therapy is needed in this case. And yes, obviously ambiguous genitalia would require gender alignment surgery. Yeah, gender alignment surgery would be done and lifelong steroid therapy would be given in this case. Next picture. This is the picture of DASH. What you are seeing over here is a vestibular opening. In vestibular opening, there is urethral opening, but the vaginal opening is covered and there is bluish, bluish tinge to the hymenal opening. Yeah, this is called as imperforate hymen. The hallmark of this condition is bluish bulging perineal membrane. Yep. It is most common cause of something called as cryptomenorrhea. Most common cause of cryptomenorrhea. Yep. That means concealed menses. Menses would be hidden behind the imperforate hymen, right? Patient has clinical feature of primary amenorrhea plus cyclic abdopelvic pain. Primary amenorrhea plus cyclic abdopelvic pain would be there because menstruation would be there in her body, but menstruation is not able to come out. Yeah. Treatment is cruciate incision. Cruciate incision. Okay. All good? Are you all on track? Yeah. Okay. Great. Next is a picture of operative vaginal delivery called as ventouse delivery, also called as vacuum delivery. Yeah. So you are seeing that somebody is applying vacuum on the head of the baby. Vertex is the requirement of vacuum delivery. Term baby is the requirement of vacuum delivery, and you have to apply at the right place. You have to apply at a place called as pivot point. Pivot point is between posterior and anterior fontanelle, more towards posterior fontanelle. It is 3 centimeter anterior to posterior fontanelle. It's called pivot point, also called as flexion point. It is 3 centimeter anterior to posterior fontanelle. 3 centimeter anterior to posterior fontanelle, pivot point. This is where we apply vacuum. Yeah, you need the patient to be in second stage of labor, and yes, the head should be engaged, station should be 0 or below, and you apply vacuum at pivot point. Okay, next point. This is laparoscopic picture of. So what you are seeing on the slide is a laparoscopic picture. Here is uterus in front, fallopian tubes are here, ovary is situated over here. But what is this thing doing over here? What is this? This is a chocolate cyst. Why do I say this is a chocolate cyst? Because dark colored altered blood is oozing out of the cyst. Yeah, this is a chocolate cyst. Yeah, and it is due to endometriosis. See, generally the size of uterus is 8 by 5 by 3 and size of ovary is 3 by 2 by 1. Ovarian size is 3 by 2 by 1. But look at this. This ovary has become such a huge ovary. It's massive. It's chocolate cyst of ovary, also called as endometrioma. And the treatment is laparoscopic cystectomy. Whenever such large cysts are there, especially more than 5 centimeters, we do cystectomy. That's what is required in this case. Laparoscopic cystectomy. Alright? Yeah. Next picture. Now this is a picture, laparoscopic picture of dash with dash. Yeah, laparoscopic picture of what it is there. What do you think it is? You are seeing hydrosalpinx. Yeah, this is hydrosalpinx. This huge, massive fallopian tube is distended because of probably inflammatory condition. Why do I say this is an inflammatory condition? Because the whole pelvis is looking red to me. This is not a normal pelvis. Everything is looking angry, inflamed. So this is PID, pelvic inflammatory disease with hydrosalpinx. Pelvic inflammatory disease with hydrosalpinx. You cannot delineate where is the ovary, where is the pouch of Douglas. You see everything is adherent to each other. This is because of inflammatory adhesions. Okay. PID with hydrosalpinx could be because of chlamydia trachomatis, Neisseria gonorrhea, or it could be because of genital tuberculosis. Chlamydias and Neisserias are responsible for acute PIDs more than chronic PIDs. I'm not telling you that they can't do a chronic PID condition, but more commonly they will present as acute PID. On the other hand, genital TB is responsible for chronic PID more than acute. Yeah, most common for chronic PID would be genital TB, and most common for acute would be chlamydias and Neisserias. Okay, so this is a picture of PID with hydrosalpinx. All right, am I clear? Next picture. This is a skin pathology called as. What you are seeing on the skin is something called as acanthosis nigricans. You may argue, sir, what is skin condition doing in gynecology? Acanthosis nigricans is a marker of insulin resistance. Insulin resistance is responsible for this. And this acanthosis nigricans condition is a part of a syndrome called as hair-An syndrome. Hyperandrogenism, insulin resistance, and acanthosis nigricans. Yeah, so this is because of insulin resistance, right? Yeah, so melanocyte stimulating hormone would be excessive, and there will be hyperpigmentation seen in the neck region of the patient. Yeah, it is seen in severe form of PCOS. Okay, acanthosis nigricans. This becomes an indication of starting metformin therapy in PCOS patient. If you see hyperandrogenism, insulin resistance, and acanthosis nigricans syndrome, hair-An syndrome, please start metformin. Next picture. This investigation is called as. What you are seeing is a laparoscopic picture, but some bluish thing is there in the fallopian tube. So what is this blue? It's methylene blue. And this investigation is called as chromoperturbation. During laparoscopy. So what is it doing? What is the use of this test? It is used to check the tubal patency. Yeah, it is used to check the tubal patency. It's considered as gold standard tubal patency test. TPT is tubal patency test. Gold standard tubal patency test, which is the first line tubal patency test, which is done in all infertile couples, patients. That is HSG, hysterosalpingography. And when HSG is abnormal, we have to do this. HSG is like first line. Gold standard is chromoperturbation, which cannot go wrong. In this case, there is fimbrial block. Why do I say so? If there is fimbrial block, then the fluid will get accumulated in the distal region of the fallopian tube. Had there been cornual block, there would have been no fluid in the fallopian tube in first place. So this is not a cornual block, this is not a mid-segment block, this is a fimbrial block. You can see end is distended. Yeah, it should be treated by fimbrioplasty. Yeah, you open the fallopian tube, you create the opening, that's called laparoscopic fimbrioplasty. That's what is to be done. Okay, right. So that's all about it, guys and girls. Thank you so very much, my dear friends. I will hand over the stage to Dr. Deepak sir now, and it's already 6 o'clock. And my dear friends, I wish you all the best, and I hope you have enjoyed. I hope you learned many things Obviously, madam had covered most of the things, but picture-wise, I've covered it all. So thank you so much, and all the best. Bye-bye.